Welcome back, everybody. We're excited for our next presenter. We were able to see her in June at our webinar, and I know we got so many fabulous comments about her. She's going to be talking about patient-focused guide to tracking your disease. I did want to really welcome her to the team here. Dr. Christofides is a physician, chief executive officer at Endocrinology Associates in Columbus, Ohio. So thank you for your time.
Thank you, everyone. It's really an honor for me to be here today. I love speaking, and you guys have probably figured that out by now. And those of you who've heard me before, but I really prefer talking to patients and their caregivers, because my colleagues, as you've already figured out sometimes from the ER, are not always the easiest to talk to. So now, that's the exception of the people here today. I really love rare disease communities more, because rare disease communities, I think, feel that sense of need to be more attentive and more sort of just aware of what's going on around you. Now, I didn't put a disclosure on there because I forgot, and I just have an added disclosure. I am now in the Ascendus EAP program, so that is a disclosure. We literally just got started, and our first patient who enrolled is here. So yay! So the point is, that is my new disclosure, and I did not add that. That was my fault. So let's talk about, this is a patient-centric talk, so I'm going to give you the secret language, so to speak, to help you navigate providers, even providers that are well knowledgeable, that you've been with for a while, or perhaps providers who are not so knowledgeable. The goals of your healthcare team are not often aligned with your goals, right? The first one is to prevent symptoms of low calcium. Now, our definition of symptoms is not your definition, and I understand that. So it is important that you convey that you are having symptoms of low calcium when you're speaking to them. And that Lynn did a fantastic job of going through those, and I will give you even more language on what to use. The rest of it obviously has to do with blood levels and urine levels and keeping the calcium from collecting in your kidneys, et cetera. So when you're talking about symptoms, one of the hardest things to pull out of patients is, what is the symptom? How do you describe the symptom? How often is it happening? And the problem is, I see this in the patient community all the time. You come in, you think we're really busy, you know we're really busy, and you minimize. We all do it all the time. Some of us more than others. My dad, not so much. He's not a minimizer. My dad is a maximizer. The men in my life are maximizers. The women in my life are not so much. It's not a dog on the men. My son is a minimizer, but that's probably because he's my child. So he knows that if he actually says anything valuable, he's going to end up in the ER. So he really minimizes the symptoms. So that's the problem, is you have a little PTSD regarding the healthcare community. You have a fear of being told you need to go right now to the ER, you need to go to the hospital. You have this fear, and this is an innate fear. And consequently, you minimize. And you wait until, well, I'm not having like the tingling to the level where I think I'm about to have a seizure right now, but I had it 3 times this week. So I want you to think about what Lynn said, and I know that it's not a scale that's been validated. I don't care. Because when you're talking to a doctor, unless they're like on the board, they're not gonna know it's not validated. So they're not gonna know that it isn't real. They're not gonna know it's not real, so that's okay. That's okay. It doesn't have to. It's real to you, right? It's real to you, and it's language that you understand. So this is why that scale is important. When you go to your new provider then, whether, let's say you're moving, you've changed providers, you've changed insurance, we all know how that works, your provider moves, or they change institutions, these are the questions that you need to make sure that you are asking of them. And by the way, as Patty alluded to, I did write a book called Living with Hypopara. It's on Amazon Kindle. It's available electronically. Or if you want a hard copy, just email me and I'll send it to you, because I have plenty of extras. Turns out it wasn't all that popular. There was also fights with the electronic rights. Anyway, so these are all, everything I'm giving you is in the book. So if you don't keep notes quickly, if you can't write quickly, you can't type quickly, it's fine. You won't, it's in the book. And it's really not that expensive, but I'm happy to send you a physical copy. These are questions that if your provider cannot answer to your satisfaction, find a new provider. These are questions that if your provider gets pissy with you because you asked them, get a new provider. These are questions that if your provider has no idea what you are talking about and why this is important, get a new provider. These are important questions to understand about your provider's knowledgeability about how to help you. Because when you're walking, talking, breathing fine, sitting there in front of them is not the time to worry about their knowledge in a crisis, right? Their knowledge in a crisis is going to matter to you more than anything. And if you're not having a crisis in front of them, how are you going to know that they can manage the crisis correctly? So with that being said, I also want to make a plug. We're all physicians here, I think, to speak to you today. I want to make a plug. There are a lot of areas in the country that don't have endocrinologists. There are a lot of areas in the country that are being managed or mostly predominantly by nurse practitioners. And I will tell you that I have come across so many amazing nurse practitioners that I would actually rather treat me than an endocrinologist sometimes, because they're that much more caring or they don't have the biases involved. And so do not dismiss a potential provider just because they're not a physician. That's all I'm going to say. And that also means you might need one or more of us like that to be your healthcare advocates, like somebody that the ER or a provider can call. So how they manage hypopara, what do you best see? And I would also just remind you, if they have firm answers for many of these, they're also probably not the right provider for you. Firm answers, right? So how many patients with hypopara do I treat? Well, I supposedly have 7 that come to see me. 1 doesn't like to come in very regularly. 1 thinks he knows everything, and 1's just got mental health issues. So that's the point I'm making, is it's not like I have exactly this many. Or what tests do I need, how often, how is it managed? The answer should always be, well, it depends. If their immediate response isn't it depends, they're probably not flexible enough to go with the flow. Like you were saying, you need your calcium at 9.4, cool. I want to make sure your urine is okay. But if their answer is, nope, your calcium max 8.5, I might have somebody who's so flexible with their understanding that in case they didn't realize, patients often forget to read the textbook before they come in, and the values aren't actually the way the textbook says. Right, so there's the science of medicine. We learn the first 2 years of medicine, and then we learn the art of medicine in the next 2 years of medical school, which usually means patients throwing the book out the window. So you have to be prepared for that. So if the answer isn't, it depends, it's probably not a super flexible physician. These are questions that you take with you to every visit, because so many of you also have other autoimmune diseases like thyroid or vitiligo or alopecia or whatever, or you are post-op and you have thyroid disease. So you're like, is this my thyroid or not? It's like the roulette, right? Is this my thyroid or my calcium today? Let's spin it. Is it black? Is it red? I don't know. Because the problem is, as we age, and we are fortunate enough to be on this planet another day longer, there are other things that can be wrong with you that could be contributing to your symptom. And the worst thing that can happen is someone's just blaming calcium, 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 and never mind ignores the fact that now your blood pressure is 180, or your diabetes is manifested, and your sugars are 300. So there are other possible causes, and that goes for you too. Don't always assume that it's your calcium. Don't always assume it's your thyroid. And the worst thing that you can do is try to argue about the micro details of your calcium. And let me give you an example. Why was my calcium 8.4 today and it was 8.3 yesterday? But why did I feel good when it was 8.4, but I don't feel good when it's 8.5? Because as Lynn pointed out, our labs are not exactly precise. They're really not. So I don't know is going to be the answer you're going to get to that kind of question. But if you come with my calcium has been kind of sort of in the same number for the last few months, but I'm feeling this way, a certain way, that's how we get to finding other things that are wrong with you. So the two-way street here. So just like you don't want me hyper-focusing on just your calcium and ignoring your other ailments, I don't want you hyper-focusing on your calcium and ignoring the possibility that there's something else wrong. Because you're human. There's other things that could happen to you. And the older we get, sadly, the more things that can be. Are there alternative treatments? And I don't mean like herbals necessarily. Yeah, be careful, be careful, be careful, because the FDA doesn't regulate supplements. And as a result, you have no idea what's in them. When I did my fellowship, my co-fellow actually did one of his papers on the amount of, I'm going to take a really common hormone that's available over the counter called DHEA. He took every supplement he could get in the store, and I see you guys are in Louisiana. I trained in New Orleans, so woo woo. We had a lot of supplement stores and a lot of herbal stores. Right? Like every other shop in Bourbon Street's an herbal store that's going to cure you of something. So he took every supplement he could get his hands on and tested it in the lab and found anywhere from 0 to like 10 million jillion value higher than what was in the label. So supplements are not the right answer. They may be, under certain circumstances, appropriate and when supervised, but not routinely, please. Alternative treatments, what I'm talking about are things like other diuretics or other water pills, right, like chlorthalidone versus thiazide, or calcium citrate in combination with calcium carbonate. The fact that I really like Rolaids as my chewable calcium supplement because it's calcium and magnesium. It's chewable, and if they ever figure out their supply chain issues, readily available. Every now and again, it becomes unavailable. So, and then the diet, as we talked about, low sodium, increased hydration, making sure there's no gut inflammation to enhance your calcium absorption, maybe taking your calcium with vitamin C. I finally have my surgeons, after 20 plus years, giving all of my post-op thyroid patients and parathyroid patients vitamin C with their calcium when they leave the hospital to make sure that they're getting improved absorption because they're stressed. They've had surgery, they've had anesthesia, God knows what else they've been on in the hospital. So I routinely have them giving vitamin C tablets to take, chewable vitamin C tablets before they take their calcium to enhance absorption because vitamin C increases absorption. These are things that you might do, obviously within supervision and conversation, but these are what I mean by alternative treatments. These are the tests that are routine, different frequencies. I, too, have my patients have standing orders. It, too, says you better call me on there. I, fortunately, have been around long enough that I have quite the reputation. Most ER docs are more afraid of me than they are of the patient. So they will do what I tell them to do. Every now and again, you get a newbie, and they have to be schooled about what it means to go against my orders. But how do you ensure you get your labs done if you are in crisis is find a nurse. When in doubt, find a nurse. They will advocate. In the hospital setting, a nurse is your best patient advocate. And if you can't get any attention from a nurse, because I've met bad nurses too. If you can't get any attention from a nurse and your health advocate isn't there with you, call the patient hotline on the hospital. So every hospital has a patient hotline that goes to one of their nurse managers that's on call, that roams the hospital. And that patient advocacy line, patient line, hotline, whatever you want to call it, the hospital operators know that number. And if you call the hospital operator and say, I'm about to have a seizure in the hospital and I can't get anyone to listen to me, I need a patient advocate, I need a nurse manager, they will get one for you. The hospital operators are your other secret weapon. I love the hospital operators. They've always been my favorite people in the hospital because they truly care about connecting people with the right people on the phone. And so if you're nice to them, and yes, it doesn't hurt to take them cookies, they're always hidden in the basements of the hospitals somewhere. I always made sure I knew where they were with every hospital I was at, and I always made sure I took them food because they were my bestest friends, always avoiding the people I didn't want to talk to. They were always good at making sure that I didn't get the phone calls I didn't want, and then getting the phone calls I needed. So obviously some of them are not going to be done every lab or every office visit, like a DEXA or a kidney ultrasound. Those are not the ones that are done routinely every visit, but the other ones usually are. So this is what a tracking log looks like. This is in the book. You can photocopy it. I'm sure Patty would be happy to send it to you guys. This is what a tracking log looks like, and where you can document your labs by the date you had them. If the assay is a different assay and it's got a different reference range, obviously you can change it. This is just meant to be an exemplar. And then side by side with that, you can have your symptom tracker. I really sometimes use very simple things, right? Like, because if you're in the room and you're like, okay, is this happening like once in a while? I don't know, once a month, once a week, every day, every hour, waking you up in the middle of the night? I tend to ask very simple questions like that, but I also ask. There are a lot of providers who don't ask, and so, Lynn's tracker might be a good one to do. This one is also pretty easy. We are ultimately all very simplistic thinkers as well. So if you tell me something's happening every day, that's a problem. If you tell me something's happening every week, that's still a problem. Once a month, I may not be so attentive to. So these complaints are good to use in the 1, 2, 3 method. Now, let me give you some other words. Throat tightness. You say that to any provider, and we're just going to roll our eyes. I get it. Because my mom, I don't wear turtlenecks because they make me choke. And I'm like, okay, Mom, I don't know what to tell you. Your thyroid's fine, your neck is fine. She just has a sensitivity to it. So throat tightness to you, though, is one step away from your vocal cords seizing and spasming and not being able to breathe. So the words I would use is, my throat, I'm choking, I'm being choked, and I'm going to get to the point where I can't breathe, because this is a calcium-dependent thing. So throat tightness, where I feel like I can't breathe daily, weekly, monthly, where my vocal cords are spasming shut. We understand those words. Same thing with muscle twitches, muscle spasms, muscle cramps, muscle weakness. I'm going to describe various things. I had a patient once who came to me out of frustration with his previous endo because his wife had just had delivered their new child, and he was so afraid of dropping the baby when he held the baby that he wouldn't hold the baby. And he kept telling his previous endocrinologist, I really have really bad muscle spasms and weakness. And his endo was like, you're not hypopara. Never mind that his calcium's 7.5. That's okay. And, he's post-op. So the point is, when he said to me, my arms are so weak and they spasm so hard, I'm afraid I'm going to drop my newborn son, now that gets your attention. So use the full sentence. Voice your fear. My fear when people say things like that to me is, you better not be on the road then. Because if you're having a muscle spasm when you're driving, that's not so safe, right? You twitch and your arm twitches and your steering wheel twitches. Depending on where you're driving, you might have really narrow lanes. You might hit the car beside you. You might hit the curb and then fling off. You might accidentally hit the gas pedal or the brake pedal in your twitch. These are voice your fear. It may not happen. That may not have been something that happens to you, and I'm not trying to give you an additional fear. I'm not trying to give you another paranoia. But these are things that you can say to your provider that will get their attention. My muscle spasms are so bad sometimes, I am worried about driving because I'm going to twitch the steering wheel or twitch the gas pedal or the brake pedal inappropriately. And that could be lethal to anybody in the car with me or around me. I guarantee you every provider you're talking to is on the road too, right? They're driving or biking or whatever, so they're going to be like, oh, I don't want to be on the road when you're on the road. The brain fog, confusion, disorientation. I know everyone's talked about thyroid. I want to remind you, depression, irritability, brain fog, confusion, disorientation, the majority of hypopara patients are women. What else happens in our 50s? Menopause. Number one symptom of menopause is all of that. Estrogen is your friend. Estrogen is very beneficial to calcium. HRT is your friend. Very much affects those main symptoms. Also muscle weakness. Also, by the way, feeling slow or feeling lethargic, fatigue. So not just don't focus on the calcium, don't just focus on your thyroid. Hormones. For the men, hypogonadism or low testosterone as we age is also not an uncommon feature, especially if we have any amount of obesity or diabetes. So low testosterone can produce similar symptoms in men. So these are, unfortunately, really big categories of complaints that you guys have that could be attributed to completely different things, all right? The heartbeat is not one I've seen actually be too problematic for people because you're not usually like paying attention to it. But if you have a heart rate tracker, and I forgot mine, I left it on the charger when I left home. If you have a heart rate tracker, use that information. Absolutely use that information. Everyone knows this, right? If you aren't aware of the changes in your EKG, the electrocardiogram, you may not know that there's actually a cardio device you can buy now. I think it's like maybe like $100, and you put your thumbs on it, and it connects to an app on your phone, and it actually reads your EKG. I don't know if you've seen that. I keep one at home, just cause. It is actually. It's quite accurate. It's very effective, it's quite accurate, and it will tell you it can't detect AFib, which is not necessarily what we worry about, but you can put your doctor's info in there, and you can have it sent to them on a regular basis. So, and you can show it on your app, like when you come into the office. So I use that for people who have more cardiac issues, or maybe they're older and they have more cardiac concerns. I definitely use that cardio IQ thing. It's just basically like it's literally smaller than this, and you just put your thumbs on it, and it tracks your heart rate and your EKG. I forget. I took my estrogen, I swear to God. I will. I'll send it to Patty and make sure she can disseminate it. I can visualize it. You know what, I can find it on my phone because I have the app on my phone. So I can like shout it out later after the break. Absolutely. So I know Lynn made a huge point about this. I'm actually going to go one step further. I have had more than a dozen, almost 24 medical emergencies in flight when I'm traveling on a plane. Not me personally, attended to. I have the most of anybody I know. I don't know why, I'm clearly the magnet for it. And everything from people passing out to people with chest pain to women miscarrying to babies with rashes, you name it. The baby I definitely gave to the pediatrician that was on the plane. Thank God there was a pediatrician. I don't do children. So I'm going to give you another piece of advice. Please put it on your phone. Every phone has a medical alert first aid app. Every phone has the capability of putting it on the lock screen. Every phone has the capability of having it on the front screen, on the back screen. I would really advise you to do that, please, because if you are passed out, do you know what we're not going to be looking for? Is I'm not digging in your shirt in the winter to look for a medical alert necklace. I'm going to look on your wrists, potentially, but I'm going to look for your phone. Why? Because I'm going to call someone on your behalf. I'm going to look for mom, dad, husband, whatever nicknames. I'm going to look at your favorites list. I'm going to look for people to call, all right? Well, what's the first thing I'm going to see, though, is I'm going to see a medical alert. So I would encourage you, yes, get a medical alert, like physical item, but put it on your phone. I actually would encourage you to hang it on your car as well. So hang dog tags. I love the dog tags because you can put a lot of information on them. Hang them on your rearview mirror. Because if you wreck, I did have a patient who had his wallet stolen from the asshole that ran him off the road. His medical alert was in his wallet. Yeah, I know, right? Like, that's Ohio for you. I don't know. I'm just kidding. I live in Ohio. So the poor guy had his wallet stolen, and he had his medical alert in his wallet. He had a card. So yes, a card in the wallet's good. Yes, a bracelet's good. Dog tags on the rearview mirror better. On your phone app is best. If you are an exerciser, if you are a workout person and you are now more active because you're on some form of PTH, there are actually there are sporty ones. There's like rope ones. There are climbing ones, and you can tag them on. There are actually ones that you can also tag onto your backpack. You can put them on your tent. You can put them anywhere. So there are many, many systems and apps you can choose from. I really would encourage you to use it. And I wouldn't put it past you, like shove it in the doctor's face if you go to the ER. You're like, I have a medical alert for a reason. I love the idea of putting your doctor's number on there. Most of my patients who have rare diseases actually have my cell phone number. Because if you have something this rare, I want you to call me when you're in the ER so I can yell at the ER doc. I'd love nothing more. Nothing more. Nothing more. It comes with age. You know, once you pass menopause, you're like, don't. Don't even cross me. So shove the medical alert in their face. Like, I have a medical alert for a reason. Like, do you want me at calcium to go so low that I'm seizing, and then you won't be able to actually save me because you won't be able to get an IV in me because I'll be in tetany like this, and you won't be able to get an IV in me. So, threatening them with the worst case scenario usually gets their attention too. Use your fear and your PTSD to your benefit. And like I said, have the medical alert in your hand. That also helps, as I said. That might get their attention. So that's the end of the presentation. I hopefully got us back on time and on track, but obviously I'll take your questions. So thank you for your attention.
All right, thank you. All right, who has questions? Give a raise of your hand. Oh, Michelle's got some online questions. She had me all panicked there. I'm like, where'd she go? Where'd she go?
If you go to the ER, what calcium level should they treat you at?
Whatever calcium level you think is a problem. If you go to the ER and you think your calcium's a problem, it isn't going to kill you to get an ampule of calcium and gluconate while you're sitting in the ER to see if it resolves your symptoms. So in the acute setting, I'm not worried about your 24-hour urine. I'm worried about you not seizing. So, if you think your calcium's a problem, then treat the calcium and see what happens, see what's left. I'm all in favor of treat first, ask questions later when it comes to calcium. There's some questions up here in the front, yes.
Yeah, less a question, more a comment. When you talked about having a twitch on the gas pedal, I had my cramp and my foot was pushed all the way down to the floor of the car. And I was actually at a conference for a different thing, and I was following someone home because I was staying at their house, and I almost hit their car because I physically had to hook my arm under my leg and yank it off the gas pedal and drive with my other foot. So if you're doing long car rides and stuff and you're doing a road trip, let's take extra calcium beforehand and make certain you're stopping for breaks when you need to, because don't be me.
Yes, so I'm so glad that you brought that up, because I used to think that I was being overly paranoid about making this recommendation because no one had ever told me that it actually happened. But if you're holding your foot constantly in a certain position, you're depleting the calcium locally, not systemically, locally. So that's why your foot seizes, because calcium, remember, you need calcium to relax the muscle in order for it to contract again. But if you've contracted it consistently, constantly, there's no calcium left to relax it. So absolutely correct. It isn't the whole body calcium, it's literally localized phenomenon in the leg or in the hand. So for those of you who have maybe not contemplated getting a new car recently, please think of it. Please think to do so. Almost all new cars have adaptive cruise. So adaptive cruise, if you don't know what it is you can set the speed on your car to whatever speed you want to go to, and it will slow you down and speed you up according to the distance to the car in front of you. And so it is brilliant. Some cars have a little bit more aggressive. The German cars are very aggressive. Adaptive cruise, just warning you, they'll whip your head back, but the Japanese cars are a little bit more gentle on their adaptive cruise. So adaptive cruise is a way around drive fatigue or car fatigue. So if you're taking long drives, and obviously it doesn't work for traffic lights unless you're driving one of the Teslas, which is it can drive itself. And then I would make a plug for that. If you are that bad, think about getting a Tesla with the auto drive mode. So there are cars that can have adaptive features for you to make you safer and make you feel more safe on the road. Adaptive cruise being one, self-driving cars being the other.
One up here.
Sir, you had a question, I think? No? Okay. Oh, yeah.
Anybody else? Questions?
Could that relate to bedtime? I get leg cramps at night in bed, but my calcium is 9.2.
So cramps that are localized at certain times of the day always make me think about blood flow. And if you're getting cramps at night when you're laying down in bed, that makes me think you might have poor circulation. So maybe wearing something that warms, like a warming blanket in your bed that increases circulation might help. Maybe taking some increased liquid with like calcium, like a calcium drink or a liquid drink. My favorite are the coconut waters. Actually, that might help before you go to bed at night. But if you're doing that, that makes me believe that might be a circulation issue in your legs. Yeah. No?
So one of the questions is it possible to have low calcium symptoms when you are on PTH therapy and your calcium levels are normal?
Of course, it's always possible you can have low calcium symptoms because the symptoms typically are coming from the ionized calcium, which is the free calcium. And when we measure your lab, it's actually usually the total calcium or the bound calcium. And there are many conditions that can lower the calcium level, the ionized, without touching the total, one of those being hyperventilation. So we were talking about that earlier in the break after Lynn's talk. If you're flying in a plane, or you've gone to altitude and you don't live at altitude, the lower oxygen level may cause you to hyperventilate and breathe faster, which blows off carbon dioxide. When you blow off carbon dioxide, it actually lowers the pH of your blood a little bit, and it actually causes calcium to be bound more. It moves ionized calcium to the bound form instead, and so lowers the free calcium in your blood and can precipitate low calcium symptoms temporarily for that reason. So it's a hypoxia thing. Now, when you're on a plane, planes are actually pressurized to about 10,000 feet, even though you're flying at 30,000 feet. So 10,000 feet is twice the height of Denver. So for those of us who are, 2 miles roughly, in that regard. So if you're used to living at sea level or below sea level, then you are going to be really affected the minute you go to anything close to 3,000 or 4,000 feet, which isn't even a mile high. So if you are in pain, if you are upset, you might hyperventilate. If you get anesthesia, you might hyperventilate. All of these things can lead to a lower ionized in the moment. So the way to fix it is hold your breath. Wow. I mean, you can't hold your breath for the whole flight, but if you're having a moment, try holding your breath.
The next question from the virtual audience is there a hormone replacement therapy you would recommend for hypopara patients?
You mean for like female hormone?
Yeah,
so
the menopausal ones.
Yeah, so a menopausal female, straight up estradiol and progesterone, not any of the other stuff, and don't do horse piss, that's Premarin. So that's what it's called. It is, it's pregnant mare's urine, horse piss. So you could do estrogen and progesterone, straight up estrogen and progesterone. Obviously, there's patches available because you're already on so many pills. And then for men, there's testosterone as well as other forms of testosterone, not testosterone therapy, generally speaking, yeah. So it's pretty straightforward. HRT is not hard, although people make it hard.
Is hydrochlorothiazide a good choice to lower calcium spillover?
Yeah, it's one of our preferred drugs to use for urinary calcium problems, and obviously chlorthalidone is another one that we use as well. Yes.
When do we need to have ionized, or is corrected calcium always equal to? I've heard two different answers.
So the corrected calcium is an estimate of the ionized, but we almost never draw ionized unless we have a real question or a concern in the immediate time, because to do a proper ionized calcium, you have to actually draw it in a special syringe that is pH stabilized. And it's called an ABG syringe because that's how we draw arterial blood gases. And so you have to use an ABG syringe on venous blood because it's pH stabilized, and I assure you no one would do it right except the person who actually cares about it, which is never the person actually drawing the blood. So from that perspective, the corrected calcium is our best estimation. But again, same thing, is it's not going to capture an immediate or urgent sort of fluctuation due to, say, hyperventilation or whatever. So it's an estimate at best. So it's always best to assume the ionized is a problem if someone's having a symptom and their total is okay. Because there's no downside to assuming that. There's only downside to not assuming that.
Thank you, Elena. That was fantastic. Can you explain, if we know, why muscle cramps tend to occur more in some people when you're swimming, when you're in the water, not a good time to have them?
Yeah, oh, great question, Lynn. As a competitive swimmer, I can tell you, I know that answer very easily because it happens even to people who aren't hypopara. Water is an amazing heat conductor. So water conducts heat extraordinarily well. So pools are typically not at body temperature. They're typically about 10 degrees lower than body temperature, usually maybe 5 at minimum, but usually 10. So when you are in the water, and that's in a pool, not just a normal body of water, you're actually withdrawing heat pretty aggressively. So you're actually losing heat very aggressively. So you're activating non-direct muscle action for thermogenesis. So you've heard of, whatever, you shiver, right? So everyone knows you shiver when you're cold, and that's non-activity thermogenesis or non-activity muscle contraction, designed to increase thermal energy internally. So when you are dropping your body temperature because you are in the water, you are then consuming more calcium than normal because your body's trying to shiver in order to increase your body core temperature. So you're chewing through more calcium than you have a right to because your body temperature can't keep up with your surroundings in that setting. So it has to do with shivering, and you may not be shivering in the water, but it has to do with non-directed muscle contraction. So it's a real problem. It's a real problem because you live in a northern climate, I live in a northern climate. Our waters are not, our fresh water, fresh bodies of water are not at temperature till September, if at all. So that's a plea to move south and go to the southern waters, just kidding. But it also means, though, that if you are somebody who likes to swim for exercise, they may not be the best choice for a hypopara patient for that reason, unless you can find a gym or a facility that will heat the pool to appropriate temperature.
Our next virtual question is there a recommendation? How do we prepare for surgery because fasting seems to trigger hypocalcemia?
The best preparation for surgery for a hypopara patient is admission to the hospital before surgery or the night before because you're fasting. So I, generally speaking, will ask my hypopara patients to go into the hospital the night before when they have a surgery that they'll have to be fasting for because of that limitation. And then, of course, you can monitor your calcium with IV and blood draws very quickly and very, very on top of it. So I usually have a conversation with my surgeons in that case.
All right. One more question, then we're going to move on.
You've mentioned several times the corrected calcium, but on your list of tests, you didn't list albumin, and I fight with my doctor to include that because I have noticed that I can be at 8.5 and feel terrible, and I can be at 8.5 and be well, and if you actually look at albumin, you can see the difference.
Yes.
And
yes.
they don't seem to pay attention to that.
Yeah, and that's because a lot of people don't know how to do the calculation for corrected calcium. And so it's interesting that you pointed that out. I actually left it off for a reason. I believe my patient when they tell me they feel bad. I believe you when you tell me my calcium's the same when I feel bad. I don't need the corrected calcium to know that you're feeling bad. So I personally, and to the point that's been made earlier, when you're doing research trials, they need to know that, and I understand that. And I'm doing albumin and other testing. I'm doing comprehensive testing and other lab work, like when I'm doing your cholesterol and your liver and so on. So I guess it's really just a matter of, do I really care that your calcium is 0.1 lower than last time for you to tell me that you feel bad today? I don't know that I really care. I care more about how you're telling me how you feel rather than the actual calcium level today, because today you feel fine, so it doesn't help me. Does that make sense? Yeah. Touche. Okay. All right, touche.
All right, let's give it up for Dr. Christofides.